delighted today to have a conversation with Rene Krause from the University of Cape Town in South Africa about a paper that she recently published in the African Journal of Primary Healthcare and Family Medicine, and it was entitled a Delphi study to guide the development of a clinical indicator tool for palliative care in South Africa. So Renee, before we get stuck into the paper, can you just say a little bit about yourself? Who are you?
Thank you, Bob. Thanks for inviting me for this interview. So I am Rene Krause. I'm from the Division of Interdisciplinary Palliative Care and Medicine at the University of Cape Town, and I'm the acting HOD Div at the moment. And I worked in this field for the past 16 years. I'm passionate about palliative care, and I work clinically in Groote Schuur Hospital. And I think this is probably why there was this push for me to actually start doing this tool, so that we could actually work towards developing a tool.
Yes. So I think what you said there is actually you're head of the division, aren't you, of palliative care, which is, I think, relatively new entity at the University of Cape Town. So congratulations on that. That's a great step forward. So this study, why did you need to do this study? What was the point of it?
Well, as I said, I work clinically, and over the past years, we have seen that many cancer patients are referred to palliative care services. However, we know that there are many more patients requiring palliative care. And as we have expanded our services in the hospital, we realized that we were seeing patients who had other illnesses far too late in their disease trajectory. And working with clinicians in the field, we realized we needed to have a trigger, and especially when working with junior colleagues, so that they realize they need to refer to palliative care or start having a palliative care approach much earlier in the disease trajectory. So we know that palliative care is an ethical responsibility that all healthcare services need to deliver, and that patients who have life-threatening illnesses suffer, and their families suffer as well, and that we really need to start integrating palliative care much earlier.
Great.
But working with junior colleagues, and I think that's very important, they don't always realize what might lie ahead for a patient. So we need to have simple triggers for them to say, hey, if this happens in the disease trajectory, please start thinking of initiating a palliative care approach.
Great. So then so essentially you developed like a tool, didn't you, to help people do that. And how did you go about, from a sort of methodological point of view, how did you go about developing this tool?
So Bob, we used a Delphi process or a Delphi study, which allowed for a structured, rigorous way of getting opinion from very senior healthcare providers. And very important, it was done in an anonymous way. So people couldn't influence each other on how they made these decisions. So we really worked hard on preventing bandwagoning or sort of agreeing, and really tried to get the opinion of these senior healthcare providers themselves.
Yeah, I think the Delphi technique was developed by the US military originally, wasn't it? So to avoid big egos kind of influencing each other. So, yeah. Great.
And that's very important in healthcare as well.
So as a result of this, the Delphi process and the consensus, you then came up with a tool, didn't you? And maybe you can share that tool with us and just talk us through it very quickly. Yeah.
So as you can see from the tool, you can see it's for adult patients, which is very important, who have advanced life-limiting illnesses and where the best available and appropriate treatment has been given and their condition is currently deteriorating. It's very important to realize that palliative care is not an excuse for poor care. And we need to make sure these patients have received the best available and appropriate care before sort of thinking, oh, we're giving up on them and they require palliative care. It's also important to realize, even if these patients have been said that their condition is deteriorating, they do have a life-threatening illness, disease appropriate care can still be provided alongside the palliative care. So it's definitely not a giving up or a giving up on a patient when we are initiating palliative care. What's very important about the tool we have developed is that the disease-specific indicators are above the sort of the general indicators for palliative care, the signs of frailty, etc. And this has been done because of our Delphi process to make sure that the clinicians have thought about the disease before just saying there's nothing further we can do for our patients. As you know, South Africa is a unique country. We have a very different disease profile and burden than the European countries. We also have different resources than the European countries or the other American countries. So we need to make sure we are having indicators for our very specific resources and disease burden. Now, in the UK, in Edinburgh, the SPICT group, and we are very fortunate to have worked with Professor Kirsty Boyd from the University of Edinburgh, who assisted us in this. They agreed that we need to have different things in South Africa. And looking at our tool and looking at our South African mortality, morbidity, this tool concluded that we need to have definitely infectious diseases included, TB especially, and HIV. And this tool was created before COVID. And just to say, as COVID came in, I thought, oh no, we've developed the tool, we didn't have COVID in. But actually the tool covered COVID because it said other infections with deteriorating clinical conditions and not responding to best available treatment.
No, good. So where would somebody find this tool if they wanted to get their hands on it?
This tool is available, as you said. It was published in the journal and on the SPICT website that is hosted by the Edinburgh group. Okay. So you can always go and look on that website as well.
So if if somebody had this tool, if I'm a GP or I'm a nurse practitioner, whatever, how would I use this tool?
I think this tool will be used firstly to teach younger colleagues and to sort of think to yourself, to read it and think to yourself very clearly, doesn't this patient need palliative care? Put it up on the wall, and especially if you're seeing diverse conditions, to think to yourself, perhaps I must start doing a palliative care approach when I'm dealing with that patient. Another important place I think this tool has is when we are looking at guidelines and where in a specific guideline palliative care approach needs to be included.
Right. So I think you mentioned just now, some of the differences that the tool has from what are similar tools in Europe and America, and this is now contextualized to South Africa, and so you've published it in this study. Is it now ready to roll? Can we, should it be used, or is there more work that needs to be done?
Well, I think like all tools, it's a work in progress, and it has to actually be used to see if there are any problems with the tool. I think a big validated study would really enrich this tool and make it more, strengthen the validity of the tool. But I think if it's not used, we will never understand the diversity that it needs to cover. And we will definitely welcome feedback from anybody on this tool so that we can strengthen the tool and it can be used in more diverse situations.
Great. So thank you, Renee. I know that you were the first author. I counted them. I think there were 16 authors, so it's a big group that published this paper. And yeah, and thank you for the work and the leadership that you're showing in South Africa around palliative care. And we look forward to your next publication.
Thank you, Bob.
Tell us more. Okay, bye
Thank
for
you.
now.
Bye.